Hey guys, good afternoon, everyone. So can you hear me?
Yep.
Yes.
So a couple suggestions. One is to us in terms of topic today. One is to chat about PAD, and the other one about venous disease, when to intervene and stuff like that. And if you guys have any more questions about other stuff, we can chat more about it. So peripheral vascular disease includes the carotid artery disease, vertebral artery disease, includes the aorta, subclavians, upper extremity, lower extremities, and uh, the renal arteries. So if we talk about any kind of atherosclerotic heart disease or vascular disease, the treatment medically is going to be statin or lipid lowering agents and aspirin antiplatelet agent, right? So always make sure there's some kind of antiplatelet anticoagulation agent. Let's say if patient has atrial fibrillation on Eliquis, you don't need to do antiplatelet for this reason. So antiplatelet agent and some kind of lipid lowering agent, especially statin therapy. And if statin intolerance, then PCSK9 inhibitors such as Leqvio or the Repatha, or for instance, Zetia and stuff like that. So that's in terms of medical management. So medical management, and obviously, if your patient has diabetes, then the SGLT2 inhibitors such as Farxiga, Jardiance, and PEFA can be used in these kind of cases. Risk factor modification, obviously, with smoking cessation, A1C less than 7%, controlled hypertension, systolic less than 140, preferably less than 130. Always be careful in the elderly population about tight blood pressure control because there's association between tight blood pressure control and syncopal episodes from hypovolemia or dehydration. Any questions about the medical management aspect? So any patient peripheral vascular disease, make sure statin and aspirin. Simple.
Did you say with Aliquis they gonna be on antiplatelet as well?
No, there's no need. Unless there's recent intervention. If there's recent intervention, you keep the antiplatelet for a month and then you stop it.
Okay.
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 There's the 0 to 2.5 twice a day. I think it's called Empire Trial or something like that. We don't really use it very much. We don't use it very much, but 2.5 twice a day on top of aspirin or Plavix and statin therapy, but I'm not very big advocate for that, especially in elderly patients.
Okay.
Any other questions about medical management?
I have a patient. This is Crystal. I have a patient that I've been consulted for. I haven't seen them yet, but they came to me to ask if we could decrease dosage on Eliquis or Brilinta, or take one of them off. He's has had a stroke before with a thrombectomy, stenting, history of CABG and significant PAD. He also has atrial fibrillation. He's currently on Brilinta and then Eliquis full dose. And I guess he just had a small cut on his finger yesterday, and they had a really hard time stopping the bleeding, so they're concerned. He's new to the facility. I don't see that he's on a PPI, so I'll talk to them about that, why he's not on something. But
okay, go ahead.
Yeah, so I'm just wondering, it looks like Eliquis would cover both of those, but do you think, and there's no cardiology or, I just see that he did see a vascular surgeon. The vascular surgeon recommended the Brilinta and the Eliquis. But I don't have any cardiology notes, and I can't confirm that he actually had a CABG. I'm gonna have to look further on that.
How old is this patient?
65.
Young. So when was the intervention? Maybe recent, right?
The most, CVA. It is not acute. It was a few years ago. He's most recently hospitalized for a left hip fracture, so as opposed to ORIF.
Okay. And no recent strokes or any cardiovascular events in the last 6 months.
Correct.
Yeah, I mean you can stop the Brilinta and keep them on Eliquis, renally dosed Eliquis. You know this aged creatinine clearance and weight.
It is. Yep. And he's okay. Yeah.
5 milligrams. Yeah, just do 5 milligrams. Document risk of bleeding outweighs the benefit. Patient preference, and just do 6.5 twice a day. This is the Brilinta. They bleed a lot on Brilinta. Look, you really need to be so similar to cases in front of the judge, right? So the vascular guy is going to be advocating for more thinning of the blood, right? And the Joe Schmo doctor, GI, whatever, anemia doctor, whatever you want to call it, they're going to advocate for less blood stuff, right? Less anticoagulation, less antiplatelet agents. And you're going to be the judge. You're going to be the one that, hey, listen, let's be reasonable and meet in the middle and not to anticoagulate too much, because the intervention cardiologists, vascular surgeons, they tend to anticoagulate a lot, and patient will leave. They don't want to have any complication with their stents or anything like that. But guess what? Patient will suffer by bleeding and anemia and other aspects. So Eliquis by itself, I think more than enough in this case. Okay, any other questions, guys, about medical management? Okay, intervention-wise, look, it's kind of can be granular a lot and very complicated. If you want to have, full-fledged, complicated chat about peripheral vascular disease, but in a nutshell, you really don't have to intervene in lower extremities when it comes to peripheral vascular disease unless you have an ulcer which is unhealed. In the setting of severe peripheral vascular disease, then intervention may be needed. If you have cold leg, in that case, that's medical emergency, okay? Or if you have severe symptomatic peripheral vascular disease, like give you example, one of my patients has severe peripheral vascular disease. He used to be a professional skier. He has not been able to enjoy his life, not been able to even walk for more than 200, 300 feet because of the severe claudication. In that case, intervention is reasonable. Beyond that, do not. If you find 90% blockage in the SFA, it doesn't mean anything if your patient not very symptomatic, especially if you have patients in the nursing homes or elderly patients that they're really not very active. Any question about that?
No.
Okay. Now, for renal artery stenosis, back in the day, when I was young, we used to send patients for intervention. Now, the treatment right now is really, if you find 80-90% renal artery stenosis, stenting is not going to help that much, right? So you treat medically, unless your unless your blood pressure is not being controlled with reasonable medical management. In that case, intervention may be needed. Back in the day, interventional cardiologists used to shoot the coronaries, drag the catheter, do a couple shots on the renal arteries, and bill for that. And if there's any 70-80%, do stent and bill for that. It's not acceptable anymore. So don't be scared that there's 80-90% stenosis in the renal arteries, because if your blood pressure is reasonably controlled on medical management, no intervention is needed. Fair?
So quick question, Dr. Ibrahim, about the renal arteries stenosis. If the blood pressure is uncontrolled, what is the best? Is it ACE inhibitors that are the best?
You can do whatever you want. They used to say
Okay.
ACE inhibitor can exacerbate kidney function by this affecting, if you have unilateral renal artery stenosis, it really doesn't, it is not valid anymore. So you choose whatever medications you want to choose, similar to any other case. In terms of blood pressure management, you want to do aldosterone inhibitor, ARB, ACE, calcium channel blockers, diuretics, whatever you want to use to control your blood pressure is reasonable. I've seen it multiple times. I've sent patients for stenting. They get the stent, they come back, still blood pressure is not, or probably blood pressure gets better a little bit, and then becomes worse again. It's the treatment's gonna be by risk factor modification, control blood pressure, and move on. Less is more. Less interventions is more.
Okay, thank you.
Okay. Now, peripheral vascular disease, talking about carotid arteries, we talk about carotid arteries in the sense that right now, unless you have 80% stenosis or more, we don't really entertain interventions. And unless you have recent symptomatic carotid artery disease, which is ipsilateral eye issues within the last 3 to 6 months, or contralateral numbness or tingling TIA symptoms in the last 6 months or so. In that case, the stenosis is not going to be is not considered symptomatic. If they don't have symptoms within the last 6 months, that's called asymptomatic. And asymptomatic, we try to rush for medical management only. Now, if your patient has stenosis more than 80% or more, then maybe discussion about surgical intervention is reasonable. Now, if you have somebody above the age of 80, forget about it. Don't even entertain that. Because medical management seems to be effective and reasonable, and intervention by doing stent or endarterectomy is about 1 to 2% stroke risk, and your stroke risk, if you leave it alone, is about 1 to 2%. So you really need to be conservative as much as you can and have a reasonable discussion with your patient. Fair? So less than 80% asymptomatic, you leave it alone. More than 80% asymptomatic, you have a reasonable discussion with your patient. Above the age of 80, leave it alone. Less than 80, then you can say, it's up to you. You want us to refer you for intervention or not. Have a reasonable discussion with your patient, and then if you have symptomatic stenosis above 50%, in the case of symptoms within the last 6 months, then intervention may be reasonable. Okay.
Okay.
Others, the subclavian arteries and others, just medical management. Not every time you find 80-90% stenosis in the subclavian artery or any other artery, you need to rush for intervention. Usually medical management is reasonable. Nothing can beat tobacco cessation if your patient is actively smoker. Okay.
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 In terms of veins, I'm gonna do some tattoo on somewhere to say, please do not burn veins. So basically, when it comes to veins of the lower extremities, and you have venous insufficiency, in that case, obviously cut down on the salt intake, raise your legs, have compression stockings, and try to avoid venous ablation as much as you can, unless you have venous ulcers and healing wounds. Because of the venous ulcers, in that case, venous insufficiency study and ablation may be reasonable. Short of that is just a joke. Complication rate is high, and the recurrence rate is very high, and I've never seen it work more than 2 to 3 years. Any question about that?
No.
Okay. Any other, questions that you guys would like to discuss? All right.
I have a question. It might be
Hey,
silly.
Chris.
Yeah, I've worked with so many different cardiologists and also I've been out of cardiology for a few years, and so practices are different. I have a patient that is well within target range for even, LDL is like 39. So I'm guessing that's why even though she has a history of a cabbage, I'm guessing that's why she's not on a statin. Is that something that I would just document that she's at target and no reason to?
No, regardless of your LDL, you have to be on high intensity statin.
Okay.
It's not really LDL target related. We up titrate, we try to add medications to keep the target right now to less than 55 or 70, whatever you want to call it, 55 if you have high risk, meaning that you have history of recent MI, peripheral vascular disease, kidney failure, diabetes, whatever. Otherwise, it should be less than 70. But if you have history of coronary artery disease or MI, or history of stenting, cabbage, or intervention, regardless of your cholesterol, and this is the issue that people do not understand, because of what we call the pleiotropic effect of statin therapy, where it's not only targeting the LDL and lowering the LDL, but it actually affects the blood vessel itself by decreasing inflammation in the wall of the vessel itself.
Even if, and is that true? Am I on mute? Is that true? Even if like the cabbage was in 2015?
Doesn't matter, really.
It doesn't matter. Okay.
It doesn't matter. Look, they tried to do this. They tried to, I'll give you an example. I'm not sure how much is that this is related, but just to give you an idea. If it was a study done, if you're above the age of 80, will stop statin versus continuation of statin, right? And they found that much worse outcome if we stop statins. So basically, statins are needed, and it's not really related to the number of this argument is valid if patient doesn't have an adverse outcome, but the patient has adverse outcome before in spite of this low LDL, and in that case you should start statin therapy because of what we believe that the extra effects of the statin beyond the decrease in LDL.
Okay.
Yeah, and that's actually that's a board question, by the way. That's always they like in medicine board, they like to tease physicians about or ask if hey, if LDL is well controlled, do we have to continue to do statin therapy? The answer is going to be yes.
Okay.
80% of physicians will say no, but that's actually a mistake.
Yes. Okay. Thank you.
Other questions? All right, guys, ladies, good to talk to you, and we'll chat in a couple weeks.
Thank you.